So let's learn a little bit more about mindfulness and based cognitive therapy. And we're going to learn from one of the best literally in the world. Let me tell you a little bit about Willem Kuyken. He's the Ritblat Professor of Mindfulness and Psychological Sciences at the University of Oxford in the United Kingdom and the director of the Oxford Mindfulness Center. He's very, very accomplished. His work focuses on depression and its prevention and treatment. In particular, his research examines how mindfulness and mindfulness-based programs can prevent depression and enhance human potential across their lifespan. Dr. Kuyken has published more than, get this, 100 journal articles. That's a lot of output, including key papers on the effectiveness, mechanisms, and implementation of mindfulness-based programs. Together with Christina Feldman, he wrote Mindfulness, Ancient Wisdom Meets Modern Psychology, published in 2019 by Guildford Press. And he's currently writing a Mindfulness for Life workbook and teacher manual as well, to be published in 2022 and 2023, respectively, also with Guildford Press. So he's a busy guy. He's going to be lecturing today and understanding the training of the human mind and how it's been a driving force for ancient contemplative traditions and more recently through psychology. Now, I could talk all day about this and not really know what I'm talking about, so let's bring in the expert. I would like to introduce for his lecture. We will have an opportunity to have a few questions after, and I've already got some that have come in. But without further ado, Dr. Willem Kuyken. Welcome, Doctor.
Can you see me and hear me okay?
We can see you and we can hear you. You sound great. Welcome.
Great. Thank you, Ken, for that very, very warm welcome. And it's an absolute pleasure and privilege to join the Immigrant Education Society and this tremendous conference hosted also by Albert Mind Biotech. And the topic of psychological approaches and the prevention of depression and the enhancement of human potential is very close to my heart. And having the opportunity to talk to you all about a program of work spanning 20 plus years and the work going forwards is a delight. I'm going to just share my screen. So just give me a second while I do that. And I will talk through a set of slides that will guide you through the topic over the next 35-40 minutes or so. So what I'd like to do is to say something about the problem of depression and frame it really as a problem of public health. Then go on to say something about how we need to respond to this problem if we're going to really make a difference. And then say something about how mindfulness, and in particular mindfulness-based cognitive therapy, has played a role in responding to this challenge. And then I want to finish by broadening that right out to the whole area of mental health in the next 50 years. I'd like to start my talk and end my talk with some practice, some mindfulness practice, and I'll come on to that in just a moment. But let me just start by saying the whole world has been shaken up by, affected by the COVID-19 pandemic, and to differing degrees, different countries, different people, different communities are coming out of that pandemic. But what I find very interesting about the COVID-19 pandemic is that it has been something that has required an urgent response and a collaborative response to something that the whole world regarded as a major challenge that needed to be addressed now by the very best minds. And that led to the development of vaccines, that led to the development of treatments, and has led to an extraordinary response in the world. And I'd like to suggest that mental health more broadly, and depression specifically, is a pandemic on a similar scale. The World Health Organization estimates that some 250 to 300 million people around the world right now would meet criteria for major depression. If you look at the world's population and you think about depression as something that can affect people throughout their life, 1 in 10 might be affected by depression. That's 1 billion people in the world right now who may at some point in their life suffer from depression. That's a major, major challenge. These are big numbers. This is one man. And I'm going to come back to him 2 more times during my talk, but I want to just bring the topic of depression really to life. My hunch would be that if I asked everybody here today, do you know someone close to you, or have you yourself suffered from depression? Somewhere in excess of 95% of you would say yes. Di was a man who first suffered from depression, pretty typically, in his late adolescence as a teenager. And then he went on to have further episodes of depression throughout his adult life. He was a school teacher, he was a husband, he was the father of two teenage children. In many ways, he was a very ordinary and a very lovely man whose life was afflicted by depression, and those around him as well, and his ability to work was affected too. And I'll come back to Di over the course of my presentation. If we're going to respond to depression, what does that response need to include? What does that need to look like? Well, I'd like to suggest, first of all, that any response to depression needs to recognize that depression is a biopsychosocial disorder. It's got personal biological factors, genetics, endocrine system irregularities, nervous system irregularities. It's got social factors that impinge on depression, to do with loneliness, to do with isolation, to do with trauma. And there is no doubt that wider societal factors like deprivation, inequality, gender inequality affect depression. Any response needs to be biopsychosocial. There is also an extraordinarily large amount that we don't yet know about the human mind and the human body. And in many ways, when Descartes, for historically good reasons, made this demarcation between mind and body, I think he set us back in quite a major way, through no intentional fault of his. But actually what we're coming to learn more and more is that the mind and the body are tremendously integrated systems. The gut biome, the endocrinology system, the nervous system, the way we think, how we behave, what we eat, the exercise that we do, all of this is like a fine-tuned system, highly interconnected. And any response to depression, I think, needs to better understand that and find ways of responding to it. And this is sort of where MBCT has come in. Mindfulness-based cognitive therapy is an approach that's come in to prevent depression. I'm showing this iceberg to communicate a couple of things. The first is that the burden of depression that is actually seen in the world is really just the tip of the iceberg. About 1/3 of the world's population live in China and India. And if you think about China and India, the vast majority of those folks who suffer from depression there will receive either no treatment, and if they do receive treatment, it'll be not very good treatment. So treatments are unlikely to really address the iceberg of depression. And the treatments that we have, they work, antidepressant treatments and psychological treatments. But I think if we're really going to make a difference to this iceberg, we need to think about prevention. And prevention can take one of a number of different forms. I'll just go through each of these in turn, and it kind of depends on how high risk someone is. If they're lower risk, a universal intervention might be appropriate. If they're higher risk, an indicated prevention. What do I mean by that? Universal is something that you might do for the population as a whole, the whole of the Canadian population, or indeed the Alberta population. You might say, if we were to improve gender inequality or social deprivation, that would more than likely have a secondary gain in terms of people's mental health, because these are known to be risk factors for depression. Selective interventions are where you work with a subgroup of people where you know if you work with that group of people on this particular issue, you'll have a downstream impact. People who have themselves suffered from mental health problems find parenting sometimes more challenging, and their own kids can be at greater risk for mental health problems. Positive parenting programs for those people are an example of selective interventions. And indicated preventions are where somebody's at really very high risk, and you try and target that risk mechanism. And that is what mindfulness-based cognitive therapy for depression is trying to do. What it's trying to do is to say the life course of depression looks kind of like this. This is somebody at birth. This is somebody throughout their life. And somebody who's prone to depression might start to see some early signs of depressive symptoms in late adolescence, mid-adolescence. That may come ebb and flow, but that can exacerbate into an episode of depression. About 50% of people will recover from that within a month or two, but many of those will go on to relapse. And the more that people relapse, the more they can get into this pattern of chronicity, this greater and greater risk for depression. And this is where mindfulness came in. It came in and said, if we can intervene here, if we can find folks who are really vulnerable to this chronic course of depression and treat and teach them skills to prevent that from happening, can we potentially shift the risk for depression towards greater risk? And so this group-based mindfulness training developed by Zindel Siegel in Toronto, Mark Williams in Oxford, and John Teasdale in Cambridge was developed about 20 plus years ago. And what I'd like to do now is just take a pause for some mindfulness practice. And I'll illustrate one of the practices from within the MBCT program. So probably more than likely, you might be in a mode just now of either listening and understanding and thinking about what I'm saying, or perhaps daydreaming. So in this first step, just take a moment to just register what's going on in your mind. Just noticing what's going on in your mind. You're alert and interested, are you distracted and in a reverie? And maybe just register too what's going on in your body. Maybe just scanning through your body, not trying to change anything, but just seeing if there's any areas of tension, any areas of intensity. So you just notice the sort of climate, if you like, of your mind and your body. And now very deliberately take your attention and bring it to your breath. Perhaps the breath in the belly. And sometimes it can help to put your hand on your belly. And all you're doing is you're allowing your mind to settle on the sensations of breathing. As you breathe in and breathe out, so everything else just falls to the background, and you choose to foreground the sensations of this in-breath and this out-breath. Nowhere to be, nothing to do, nothing to fix, not trying to get anywhere. Simply letting your attention, letting your mind rest on the sensations of breathing. And then whenever you're ready, just broadening your awareness out now, a bit like a torch beam, broadening it out so there's a sense of floodlighting the whole of the body. The soles of the feet, all the way up through the legs, the pelvis, the torso, hands, the arms, the head. Broader awareness of the whole body in this moment, breathing. Okay, thank you. So I'm just going to go back into kind of a mode of presentation, but just to maybe make the point that that ability to anchor our awareness, our attention is available to us in any moment throughout the day. That thread of of our breath is there from the moment we're born to the moment our lives come to an end. So mindfulness-based cognitive therapy is an 8-week program, normally taught over 2 months in groups of about 15. Is it effective? So this was published in JAMA Psychiatry in 2016, and we looked at 9 randomized controlled trials with 1,200 people in them, and we asked the question, is MBCT more effective than comparator conditions at preventing depression over 1 year of follow-up? And I'm not going to unpack this this graph. It's for those of you who know, it's a forest plot. For those of you who don't, it's a way of collating the data from different studies to see whether or not the studies together tell a story. And the studies together tell a very clear story that actually MBCT outperforms with complete confidence the control conditions. It is indeed an effective approach to preventing depression compared with the comparators. And what about what I said earlier about the comparator of medication? How can it fare to help people come off their medication, which is probably the mainstay approach for people with recurrent depression? So that's what we did in this study. This was 400 people who either received MBCT and came off their medication, or we asked them to stay on their medication for 2 years. It was a randomized controlled trial. And what you can see, this was published in Lancet in 2016, that the rates of recovery and relapse were about the same in the 2 groups. So we went back to the IPD meta-analysis and we took all of the studies asking the same question: how does MBCT compare to maintenance antidepressants? That's down at the bottom here. And it provides clear evidence, I think, that this can provide an alternative to people staying on medication long term. That's quite literally hundreds of millions of people around the world potentially can learn skills to stay well in the long term. What else is happening in the field? The field is really coming of age. It's coming of age in a way that I think is equipping it to help us respond to how people might find a sort of a compass and a way to come out of this pandemic. There are some guiding ethical principles that have been published. There have been consensus statements about how to train MBCT therapists, teachers, and there's training that goes on in Canada, in North America, and as you can see in this image here, we've been doing training in mainland China, in Taiwan, and in the United Arab Emirates, amongst many other countries. And finally, we've worked with policymakers in many countries around the world, and I think it's now more than 10 countries recommend as part of their clinical guidelines that people with recurrent depression should have access to mindfulness as a way of staying well in the long term. So just to summarize, it's not a panacea, but it offers those with a substantial history of depression a new approach to learning skills to stay well in the long term. So where are we going now? Well, one of the bits of work that we're doing, which I want to tell you about, I want to tell you about some more newer work in the next part of my presentation, and then broaden right out to mental health promotion. It's what about young people at really high risk of depression? They've got low-grade depressive symptoms. So led by my colleague Tamsin Ford, we have demonstrated that MBCT for this group with parallel classes for their parents is an acceptable and likely effective way for young people to learn the skills to prevent depression before they get into a lifetime of recurrent depression. We're doing a larger scale project at the moment to see if that can be extended and replicated. When we wrote the meta-analysis, Richie Davidson, who is at the University of Wisconsin, said one of the main things that is needed for this field to move forwards is a better theoretical understanding, a better map, if you like, of what is happening in MBCT to enable you to focus on that mechanism more acutely so you can get better outcomes. And that's what we're doing. I don't know if how many of you have seen this wonderful book by Matthew Johnston. It's called I Had a Black Dog. It's an illustrated cartoon book. The WHO, World Health Organization, put it on its website with multiple translations into multiple countries. It's been seen many millions of times. It's the most beautiful description of the phenomenology of the experience of depression. And this is an image that I think captures psychologically what can happen with recurrent depression. So it's 3:20 in the morning, and this man has woken, early morning waking, it's called, as a symptom of depression. And you can see on the wall behind him all the thoughts that he's having. Life is too hard. I'm no good. I feel so bad. I'm going to be so tired tomorrow. I can't remember what it's like not to feel this way. This escalation of negative thinking proliferates like kindling in a fire and can lead very quickly into a downward spiral and into an episode of depression. Just a small shard of negative thinking can very quickly escalate into depression. And this has been shown to be a psychological mechanism in depression that MBCT targets. MBCT teaches people to recognize these early warning signs of depression and be able to relate to them differently. And this is a study that a number of studies demonstrating this is the case. And this is a really nice study that we're about to submit, in which we ask people at risk for depression to go through an MBCT program or a control group. And then we put them in a scanner. And we look to see, after the MBCT, what had changed in those who hadn't experienced MBCT. And it was the salience network that was consistently different in the two groups, a network that's centrally involved in making judgments about what to pay attention to, what to engage with, what not to engage with. And that was correlated with a measure of decentering, a measure of a person's ability to step back and see their negative thinking in a different way. The final thing I want to say about mechanisms, which I think is really key, is that somebody once said to me with depression, you know, I'm familiar with the dark and I'm less familiar with the light. And moving out of depression is quite scary because I'm being asked to move into the light. And I think one of the things that we need to do if we're going to make a real difference with depression is actually to teach people to live in the light. And there's very good evidence now emerging from both cognitive behavioral therapy and MBCT, mindfulness-based cognitive therapy, that people are learning not only to work with negative thoughts, but they're learning to recognize and savor the many good things in their lives, which previously they may have just skated over or not paid attention to. And this strengthening of the positive valence system, I'd like to suggest, is a really important part of the process of recovery from depression. So here we see Matthew Johnston's figure again, sitting on the sofa. The black dog is still there, but he's in the window now. What this man has developed is an ability to have a different relationship to the black dog, a sort of befriended relationship to the black dog. So he's less tormented by it, and he's somehow, to use the phrase I used just now, decentered from that very negative thinking. So I want to come back to Di and tell you about what happened with him after MBCT. He said he kept in touch with me for years, actually, and he wrote to me and said, Willem, the skills you taught me were really helpful with my depression, and I've managed to stay free from depression. But I want to let you know about the ways I've been using those skills in other areas of my life. He went on to develop bone cancer. And he used the skills he learned in mindfulness to be able to work with the pain and to work with the uncertainty of the diagnosis and to work with all of the stresses of the treatment. He had a bone marrow transplant at one point. And then he wrote to me later still about how he knew that the treatment had failed and that he was likely to die from the bone cancer, and how he was now able to develop a real sense of compassion towards his teenage children and his wife, because for him now he had a certain acceptance of what was happening, but he wanted to really reach out and show compassion to those who were very in pain about his illness. And I remember reading those emails that he wrote to me with a real sense of, gosh, this is somebody who has taken some of these skills and really used them throughout his life in relation to his own pain, in relation to his family and his relationships, and more large-scale issues of his own mortality. And this is the book that was mentioned in the introduction that Christina Feldman and I spent many, many years writing, where we brought together the best ideas from Buddhist psychology, ancient wisdom, and from modern psychological science to try and understand what it is that Dai was describing. What are these skills that people learn? What is the roadmap of change that people are going through? And I really love the quote, between stimulus and response, there is a space. And when we can recognize that space, that is the space where we begin to have choices. That is the space where we begin to have freedom. And I think fundamentally, that's what mindfulness is helping people to do, is to create a space, both in their inner life, but also in their outer life, that enables them to have that freedom, have that capacity to respond differently. People learn attentional skills. They learn, instead of their attention being continually hijacked and on automatic pilot all day, to see when that's happening and to bring their attention back to where they choose to place it. They learn to decenter, to step back from, and see that there are new ways and different ways of knowing, relating to both the positive and the negative, to be able to think and have a conceptual way of knowing the world, but also an experiential way of knowing the world, that actually our bodies and our phenomenological experience can be tremendously wise, incredibly powerful. And mindfulness teaches people that. And from that place, people start to realize that they have a choice to respond to the cues of pain or conflict or difficulty, or, as we saw in Dai's case, to some of the larger challenges in life. Dai said to me, I wish I'd known what I know now. As a teenager, it would have avoided a lot of suffering. And prevention across the lifespan means bringing things down much younger. And that's work that we're doing at the moment. So at the moment, we're spending 7 years, we're just at the very tail end of this, where we have asked whether we can take Dai's invitation and teach young people, 11 to 16, mindfulness, and see if we can actually enhance their resilience, prevent mental health problems, and improve their well-being. This is Jeffrey Rose, the enormously influential public health epidemiologist, who argued that if you want to make a major difference in major public health challenges, he talked about heart disease, he talked about obesity, but this extends equally to mental health. We need to move from this sort of risk reduction approach, taking, like with MBCT, people at very high risk of depression, and trying to move them towards greater mental health. We need to take a population approach. So this is the whole population, from really poor mental health to normal mental health to flourishing. We need to have an approach that takes the whole population and moves it towards the right. How do we do that? By targeting key mechanisms that underpin mental health, using safe, accessible, and potent training methods, which is what mindfulness provides. We looked at the literature in young people. We found quite a lot of randomized controlled trials, and we did another systematic review and meta-analysis. And the evidence is really promising that these schools-based approaches could potentially reduce depression, anxiety and stress, and negative behaviors compared to control conditions. So what we're doing now is a large-scale trial, 85 schools, 28,000 children, and we are asking that question. Can mindfulness training improve young people's mental health and resilience? I can't tell you the results just yet, because we just today, in fact, submitted them to a journal, and until they've been peer reviewed and published, I can't say what they are. But this was an editorial recently in the New Scientist, just last week, I think it was, taking stock of this whole field and saying, in the early days, the research was very promising, but perhaps overstated. Following that, there was a bit of a backlash where some of the concerns were similarly overstated. But actually what we have now is a field that's really maturing in areas like depression and pain. MBCT and mindfulness-based stress reduction provide really promising ways of giving people skills for life that they can use in relation to major problems that we have in the world. So I want to just finish with kind of a challenge, if you like, for the next 50 years. This is something I wrote in the Huffington Post a little while ago. And this picture is of my grandfather. This is my grandfather just here and my grandmother just here. I think they were on holiday somewhere. And my grandfather died at about the same age that I am just now of a heart attack. And he probably never exercised in his life in terms of vigorous physical exercise. He ate unhealthily, he smoked, I think he smoked a pipe. His coronary heart disease wasn't detected. There were no screening or anything like that. And so when he had a heart attack, it was fatal. If he'd been born at the same time as me, his diet would have been different, his exercise regime would have been different, and actually blood pressure problems and early signs would have been spotted. And here's my challenge. Can that normalcy, that everydayness of diet, of exercise, of red meat, can that also apply to questions of mental hygiene, habits of mind, habits of behavior that are associated with mental health? Can we teach and learn foundational skills for life? We know what those skills are. Psychologists know what they are. Ancient wisdom points to what they are. And I love this, this quote from Vikram Patel's Lancet Commission on Mental Health. Mental health is a fundamental human right. And if we're going to do that, he argues, and I'd argue as well, we need to have a staged and scalable approach. We need to think about how we can reach as many people as possible. And the reality is that's going to be digitally. And if you look at apps like Headspace and Insight Timer and Calm, they have introduced about 400 million plus people to mindfulness. Beyond that, we have other things like books. This is the best-selling book on mindfulness to date. 1.5 million copies plus sold. When a recent trial taught this curriculum to university students, it was able to demonstrate that through the course of a university term, a university semester, from pre-intervention to post-intervention through the really stressful exam period, the group that had been randomized to the mindfulness training compared to the other group showed improvements in well-being and lower distress, and that became particularly marked during the exam period. These are skills that can be taught in the mainstream to groups like university students. Just give you a couple of other illustrations. This is a study that's about to come out where we compared giving people the book, saying get on and read this, with bringing people into a class. And the findings are kind of, in a sense, obvious, but nonetheless good to have. If you give people a book, it's much more accessible. People can do things in their own way, at their own pace, but the effects are going to be smaller. If you ask people to come into a class, they have to find the time and make the commitment. The accessibility is reduced, but the effects are larger. So actually across this staged, scaled model, we have digital approaches here, we maybe have books here, and then we begin to have classes. This is a curriculum that we've developed, which is teaching people these mindfulness skills for life. We call it MBCT for life. And this is a study with healthcare professionals, where we were able to show that in this more intensive curriculum, we see medium to large effects on stress, well-being, anxiety, and depression in these healthcare professionals who've learned this skill for life. And just finally, what we've done is we've said many people want to go further. And so we've developed a curriculum where people continue to learn these skills really for life. So just to summarize, these population-based mental health promotion approaches can be accessible, safe, and potent. What we're doing is teaching people these foundational skills of attention, of being able to take a different perspective, being able to respond and not react. These reduce distress and enhance well-being. They can be taught in different formats and contexts, digitally, face-to-face, books. I've not said very much about this, but the evidence is fairly clear. This is at least as cost-effective as other approaches, and possibly, if one were to do longer follow-ups, more cost-effective. I want to go on so that we have some time for questions, and just finish with this quote again of mental health as a fundamental human right, and just pose to you a challenge, if you like. Can you envisage a world without the devastating effects of depression, where people enjoy mental health and well-being as a human right, and are resourced to meet the kinds of challenges that we're going to face in the next 50 years? I want to finish just by acknowledging that all the work I've presented, work that we've done over the last couple of decades, has been teamwork, and this is the team of colleagues that I've been privileged to work with, and funded by the Wellcome Trust and the Rip Black Foundation. There are a set of key resources. I'm happy to make this available afterwards for anybody who wants to learn more, find out where these books are, find out where the PDFs of these papers are. I'm very happy to make this set of key resources available. And I want to just finish by thanking you for your kind attention for the last 35 minutes or so.
Thank you very much, Dr. Kuyken. Absolutely fascinating. Now, well, first of all, let me congratulate you. It's some busy Wednesday or Thursday when you've sent a research paper to a journal and then have time to actually speak with us as well. So you pack in a lot, you and your colleagues. So congratulations on that. I'm going to open things up to questions now. We do have a portal open, and I'll get to Juanito's question in just a moment. But if you do have questions for Dr. Kuyken, this is your moment to ask. I've got a few here, and so we'll explore. You've covered a lot of territory here, but let me start. I'm gonna actually flip it back on you a little bit. You posed a really interesting question at the end. Can you envision that world where, depression is not a natural state in the sense that, it's something that we can deliver wide scale to impact and to improve? Let me ask you that, through the work you've done, through the intensive work you've done for decades in this area, and particularly around mindfulness, how optimistic are you that we can reach some solutions that are broad scale using some of the research now and where you hope things emerge to? What keeps you optimistic about it?
Great question, Ken. And I think what keeps me optimistic is, well, a number of things. I think the human ability for creativity, for development, for innovation has just been demonstrated through this pandemic. We have got at least 5 very effective vaccines developed on treble, if not quadruple, if not tenfold speed. That has been, here in Oxford, the lights were on 24 hours a day in the labs where people were developing the Oxford AstraZeneca vaccine. What we now know about heart disease means that heart disease is slipping down the rankings of major public health problems in the world because people are implementing that. I'll just give a small example. At the time of my grandfather's heart attack, it was routine for patients who'd had a heart attack to be placed in a very quiet part of the hospital away from the nurse's station so that they could rest. That led to many fatalities because, of course, when they had some problems, the nurses couldn't get to them fast enough and they weren't detected. So we now know that that's really a very bad idea. So I think things like heart disease, the pandemic, teach us that actually human imagination and innovation can make huge inroads. And I also think that mental health is actually not rocket science. That actually, yes, there's still a lot we don't know about the mind and the body and the brain. But some of the basic things that drive depression, trauma, abuse, inequality, people being incredibly judgmental of themselves. These are things that we know about, and they're not difficult. Well, they are difficult, but they're not difficult in principle to shift and change.
It's interesting. Yeah, there's the audience that is listening. There are some, professionals like you, and we'll be hearing from some of those later. But there's also just regular folks, in online. You spoke with some of the root causes of depression, the psychosocial factors, physical, social, sociological. Juanito in the chat asks, how can we reduce, if not eliminate, those root causes? And are there even daily habits or small routines that are helpful? Because this feels like such an enormous problem. And of course, tools like mindfulness are tools, but it just feels, you speak of hope, but it just feels overwhelming. What are some things we can do in our own lives to actually help push on some of those root causes?
I just mentioned two, which, of course, just so I make a caveat here, because I don't want to sound like a Pollyanna. There are some people in really tough circumstances, immigrants who have got very poor access to resources. Their diet is necessarily not great. They've come from a history of trauma and PTSD. So I don't want to minimize in any sense the real adversity that drives distress for many people. But for the general population on that, and the last part of my talk about mental health promotion, I'll just give two. Sleep. In the area of mental health, people used to think of sleep as being an epiphenomenon of mental health problems. But now there's more and more of an understanding that actually if we can take care of our sleep and we can have better sleep hygiene, our mental health will improve. And people go, oh, well, I'm really busy, I've got young kids. But actually, there are things we can do, really obvious things, a regular bedtime, having something relaxing to do before. And, again, it's not rocket science. Sleep is not rocket science. And then another is our relationships, is to, as best we can, I know this isn't possible for everybody, but to look at our relationships and which are nourishing, which are supportive, which enrich our lives, and to spend time cultivating those relationships. That's a very important part of the social part of. And I think in terms of, you want to go just do one more layer up, I think women are 2 to 3 times more likely to suffer from depression than men. Lots of potential explanations for that, but I think gender inequality is one of them that drives that. So I think efforts to address that inequality will also have, at a societal level, an impact on depression. So those are 3 examples, Ken. And so I feel hopeful, I guess, about all 3 of those.
Another big question, but I'm hoping you can take it down into bite-sized chunks. What are your thoughts on mindfulness and comorbid disorders, other disorders that lead to depression? Can mindfulness play a role? And, does that, with or without medication, like what does that look like in sort of the toolkit that someone would have if they've got other disorders that are influencing their health?
I think that's one of the reasons I use the example of Di Cohen, because that's exactly a good example. These kind of skills, and that's why I use terms like foundational skills, attention, shifting perspective, responding, not reacting. That applies equally to things like pain and disabling conditions, as it does to sort of more purely psychological conditions. And I think, Ken, you're probably pointing at this, and this is maybe where the question is coming from, is that I think that duality of mind and body is an arbitrary duality. I mean, the most obvious example is if you think of the most delicious food that you could possibly imagine right now, your mind starts to salivate. Your mouth starts to salivate. So with a thought, you have created a bodily reaction. And, if you have a really bad night's sleep, your mind is cloudy and you feel a bit grumpy. So your physical state is shaping your mental state. It's a very, very intertwined dynamic. So I think things that change the body and things that change the mind are just in this sort of interplay that we're just beginning to discover. Heart disease, depression, pain, depression, obesity, depression, they're highly comorbid. And I think these skills can speak to all of those conditions.
Dr. Kuyken, I want to get personal for a moment. Tell me, was there a moment you're obviously a very learned man and you could have pursued many areas of psychology, but you chose this one. Can you take me back to the moment where you went, this is the path I want to pursue? And what was it about that moment, if there was one, or a constellation of moments, that made you think that this was territory that really needed to be explored, and in this moment?
I worked at the World Health Organization for 2 years and traveled a lot to places like India, China, Eastern Europe. And I remember having a real sense, and I was talking to a lot of health professionals, a lot of people with chronic physical health problems. And I had a real sense that there was a wisdom around the world that was not being tapped into. And I remember being in Thailand, and I'd been to some of the monasteries, and in India, I'd spoken to some of the people from the Hindu faith, and I bought a book at the Bangkok airport, which was sort of introduction to Buddhist psychology, and I read it on the plane. And some of the wisdom in there about how the mind understands distress, how it can be freed from that distress, how it can be, if you like, it's a strong word, but liberated, was really interesting. And in those days, you could go and sit up with the pilots in the airport. You'd say to the stewardess or the steward, can I go to the cockpit and sit with you? And I spent much of the flight flying back from Bangkok, sitting in the cockpit with the pilots, looking up at the night sky. And I had a sense of this extraordinary wisdom from ancient traditions can be brought together with modern psychology to address some of the real challenges in our world. All of the challenges we face, climate change, for example, political unrest, polarization, all those challenges are going to need to be solved by the human mind and the human heart. And we have a method for training the human mind and the human heart. We're just not utilizing it fully. So I think in that moment, on that flight back from Bangkok, I thought, here is a methodology for training the human mind and the human heart that, if it was more mainstream, could make a massive difference.
Fascinating. I want to talk about governments. We're very lucky in this conference to have some significant support from the provincial government here in Alberta, our municipal government. You heard from a couple of city councillors earlier, and I know that there's work even happening at the federal level. But with something like mindfulness-based cognitive therapy, MBCT, how can governments support this work and moving it forward, particularly in Canada? This is where the majority of our audience is, and many people on this seminar want to make this happen, but they will need supports. They will need partners through government. What words would you happen if Prime Minister Trudeau was sitting here, or Premier Kenney in Alberta was sitting beside me? What would you say?
I think one of the first things to do that I think policymakers can definitely do is to mandate things that are evidence-based. So we know that MBCT for depression is effective. We know that mindfulness-based approaches for chronic pain are effective. These are two massive problems. Mandate it, put it in clinical guidelines. And then patients will say to their family physicians or to their healthcare providers, look, this is mandated. Why is it not available to me? That's kind of one thing that they can do. And the other is, I think any implementation effort has a sort of top-down and a bottom-up element to it. So one can raise awareness and say, look, these, like if you take the example of obesity and heart disease, people now know that smoking is unlikely to be good for your heart or your lungs. So there's a sort of public awareness, which is sort of a bottom-up thing, and then there's sort of top-down thing. But I think probably one of the major things that can make a difference is putting some resourcing into training good MBCT teachers. If you can train good teachers who can then staff the health service, who can be on hand in schools, in prisons, in occupational health departments, the quality of that training. I mean, I once, was training in Shanghai, and I looked around the group, and on the back of an envelope, I calculated that the group of people sitting there that we had just trained would reach tens of thousands, if not hundreds of thousands of people in the course of their career. So I think investing in the training of mental health professionals to deliver these interventions, I think, is a really good investment.
Yeah, it seems to me it's fascinating because so much of our healthcare system, or some would maybe even call it our sick care system,
Yes,
is really missing the mark. It's too late
yeah,
in the cycle. Like you said, it
yeah,
doesn't prevent that chronicity. And I think that's what you're speaking to.
yes. Thank you, Ken, for pointing that out. That analogy people say is you park the ambulance at the bottom of the cliff, and actually what might be more sensible is to, at the top of the cliff, make sure that people are not wanting to jump off it. So that kind of downstream and prevention, absolutely. There are often no incentives for healthcare systems to do that work, but it's very likely to pay off big time. But on a longer time window than many policymakers think, I guess.
Dr. Kuyken, you've given us a lot to think about. You've given us some tools. I'm happy some of this work is happening right here in Alberta. You spoke about mindfulness apps. We literally just launched one today with both Alberta Mind Biotech and TIES. That's available for a free download. So yet another step in good made in Calgary research when it comes to the Canadian contribution to this work. I'd like to thank you. You're a very busy guy. And like I said, on a very busy day, you took the time to spend with us. I know that our audience was very well served. So thank you very much. And more to come from you. I know we'll be following your research with interest. Thanks again.
Thank you.
All right, that is Dr. Willem Kuyken from the University of Oxford. There is significant work happening, and you've literally just heard from one of the best. He is one of the preeminent researchers and practitioners in this space.